USMLE style question on Hyper-IgM syndrome. Question: a 6-month-old boy is brought to the pediatrician due to recurrent bacterial and opportunistic infections, including Pneumocystis pneumonia and chronic diarrhea. He was born at term to non-consanguineous parents. Since birth, he has had multiple ear infections, pneumonia, and a persistent Candida diaper rash. Laboratory findings: IgM high, IgG, IgA, IgE, low or absent, flow cytometry, normal B-cell count, low CD40 ligand expression on T cells. Neutrophil count, normal. Which of the following is the most likely underlying cause of this patient's condition? A. Defective CD40 ligand expression on T cells. B. Defective Bruton tyrosine kinase, BTK. C. Impaired class switch recombination due to AID deficiency. D. Absent B cells due to defective B cell maturation. Defective NADPH oxidase in neutrophils. Answer: A. Defective CD40 ligand expression on T cells. This patient presents with Hyper-IgM syndrome, an X-linked recessive disorder caused by a mutation in the CD40L CD40 ligand gene on helper T cells. The defect prevents B-cell class switching, leading to high IgM, default antibody class, low or absent IgG, IgA, and IgEs due to defective class switching, recurrent bacterial infections, e.g. Streptococcus, Staphylococcus, Haemophilus, opportunistic infections, Pneumocystis jirovecii, Cryptosporidium, Candida. Classic USMLE clues: recurrent sinopulmonary infections, otitis media, pneumonia. Opportunistic infections, this is pneumonia, Candida, Cryptosporidium. Low IgG, poor opsonization, risk of bacterial sepsis. Normal B-cell count, but defective class switching. Key features of Hyper-IgM syndrome. Feature findings in Hyper-IgM cannot class switch. Genetics: X-linked recessive, 40L mutation on helper T cells. Immunoglobulin levels: high IgM, low IgG, IgA, IgE. B-cell count: normal, but cannot class switch. T-cell defect, defective CD40L, no B-cell activation, class switching. Infections: recurrent bacterial infections, opportunistic fungal and protozoal infections, opportunistic pathogens, Pneumocystis jirovecii, Cryptosporidium, Candida. Autoimmune risk increased. Diagnosis: flow cytometry, absent CD40L on T cells. Treatment: IVIG plus antibiotic prophylaxis, e.g. TMP-SMX for PCP prevention. Why not the other options? B. Defective Bruton tyrosine kinase, BTK. Describes X-linked Bruton agammaglobulinemia, XLA. Presents with absent B cells and very low immunoglobulin levels, but this patient has normal B cell count and high IgM. C. Impaired class switch recombination due to AID deficiency. Describes autosomal recessive Hyper-IgM syndrome. Similar presentation but less common and not X-linked. D. Absent B cells due to defective B cell maturation. Also describes XLA, but this patient has normal B cells. Effective NADH oxidase in neutrophils. Describes chronic granulomatous disease, CGD. CGD patients have abscesses, granulomas, and infections with catalase-positive organisms, e.g. S. aureus, Aspergillus nocardia, not Hyper-IgM's immunoglobulin pattern. Key takeaways for USMLE: Hyper-IgM syndrome, X-linked CD40L mutation, no class switching. High IgM, low IgG, IgA, IgE, recurrent bacterial and opportunistic infections. Opportunistic pathogens, Pneumocystis, Cryptosporidium, Candida. Diagnosis: flow cytometry, absent CD40L on T cells. Treatment: EVG plus TSMX prophylaxis. Would you like a question on